Asked by Yannis to present a case with valving MAC, and I had one case that we did. So MAC is difficult for surgeons, it's difficult for interventionalists, TEER is difficult with MAC, TMVR is difficult with MAC. Valving MAC is used with balloon expandable technologies, but doesn't have the same results as valve-in-valve or valve-in-ring. And there are anchoring factors. The most important limitation usually is MAC cases have got narrow LVOTs. So this is a lady that she's 78 with severe mitral stenosis, very symptomatic, and also lots of pulmonary issues, pulmonary fibrosis, restrictive pulmonary pattern, home oxygen. And the echo shows preserved ejection fraction, preserved LV size. The mitral mean gradient ranges from 8 to 10 millimeters, and these are the values. So there's a systolic pulmonary pressure, but it's driven mostly by the elevated wedge pressure. So initially we thought maybe it's the respiratory issue, but there was definitely an element of gradient between the wedge pressure and the LVEDP. And this is how it looks here. You can see that the leaflets are immobile. There is a flow acceleration. This is, of course, during sleep, so the gradient here was, I think, 8. And the analysis was that there was circumferential MAC. There was a little bit less MAC on the medial part of the valve, but generally, on the lateral part of the valve, sorry, but generally there was quite a lot of MAC. And the area was in the order of 6.8 square centimeters. And the projection for different balloon sizes, valve sizes for the LVT was hopeless. But we were lucky because the septum wasn't that thick. And you can see how the projected valve protrudes into the LVOT. We had two issues. First, the length of the anterior leaflet was 28 millimeters, so that's a bad prognostic sign. The second thing is that the good thing is that the AVS thickness was only 11 millimeters. So most of the LVOT occlusion would come from the leaflet. So what if we could implant the valve into the leaflet? And this is a procedure called Batman that was introduced by Tarek Helmi in the transapical cohort, whereby you perforate the anterior leaflet close to the base of the leaflet, but not at the base of the leaflet. And then you create some balloon dilatation and you implant the valve inside the leaflet and, of course, inside the annulus. And this way you translocate the leaflet to the posterior aspect, thereby taking it away. The other option, of course, would be to lacerate the leaflet, doing a tip-to-base lampoon. But we thought since there was some calcium on the leaflet, it would be difficult to do. So this is how we did the procedure, and this is the actual recorded live case. So the transeptal puncture we try to do inferior and posterior. Posterior gives you height, but inferior gives you a good trajectory with respect to the valve. And this is different to the TEER procedures. We, of course, implanted a thromboembolic protection, a sentinel device. You can see here the orthography, because we don't know what ballooning the leaflet with this calcium will do to the debris, and also implanting a valve inside this calcified annulus. Usually MAC calcification is a lot more than aortic calcification. You can see here the implantation of the sentinel device that was somewhat challenging, but we were able to deploy both baskets in the right and the left side. So once we did that, we had the transeptal and the sentinel implantation, then our setup was to put an LV catheter through the left femoral artery. We had it also prepped for a potential balloon pump implantation or hemodynamic support. So this way we had simultaneous pressures from the LA and the LV and also from the LV and the aorta. So you can see that baseline, there was no gradient for pressure calibration purposes. The LV was slightly higher than the aorta, and we took that into account. Then the next step would be to put a stiff wire inside the left atrium and then exchange for an Agilis steerable catheter in order to direct our trajectory to the base of the anterior leaflet. So this is the Agilis catheter being inserted, and in a minute we'll just take the wire out, the dilator out, and just curve the Agilis catheter to the anterior leaflet. The aim now is to get a good position above the anterior leaflet in the A2 area, not very close to the base, but also quite far away from the tip, somewhere in the middle. And this is where imaging is very, very important. So you can see here we're working in the commissural and X-plane view. You can see on the right of the picture here I don't know if I can show this there. We're trying to get above the leaflet. It's a laborious process. It took us 20 minutes to get orientated, but here you can see that the Agilis catheter is going above the middle of the leaflet there. And by being very specific, we debated whether we should go more towards the base from this calcific node or towards the tip, but we didn't feel that there was enough tissue if we went towards the center of the valve, so we just directed it here. You can see we went straight with the wire. The wire is the back end of an 035 wire. And once we were happy with this position, then the plan was to electrify the wire and cut through the leaflet. So you can see the final position on the 3D echo here. We were happy, and then we just electrified the leaflet. You will see in a minute the movement of the wire towards the LV going through the leaflet. So we're happy with the position now, and then we will cut through in a minute. We're measuring the distances between the tip of the leaflet. We just spend our time trying to make sure, and this is, I think, the cutting. See, there were some bubbles, but you can see how the wire moved towards the LV now. Of course, not very far. We had a multi-purpose catheter in, and we exchanged for the multi-purpose catheter. But we are happy that we went through the leaflet, multi-purpose goes in, and then we just exchanged for a 7 French JR guide catheter, and then we put 2 Safari wires or Innovi wires, supportive wires, inside the LV. I'll just forward that a little bit because we're running behind. So the 2 wires now going into the LV. And the plan is to use both wires, to use one wire to put a balloon, a 14 millimeter balloon, Atlas balloon, high pressure balloon, to prepare the septum and the leaflet, and on the other wire to have the balloon expandable. We used Myval here, 29 millimeter. So the initial assumption was for a 30.5 millimeter valve. We undersized a little bit. You can see the LV angiogram, how the wires go through the leaflet. And then this is Myval on one wire and balloon on the other wire. So body wire, body balloon technique. And this is, we're now inflating the 14 millimeter balloon inside the leaflet. You can see the waist. So we took our time here. The leaflet is tough, I can tell you. So it took about 8 or 10 atmospheres on the Atlas balloon. And then here is the ballooning. You can see the blood pressure of the patient being a little bit compromised. We deflated, we pulled back the leaflet towards the septum to do septostomy in order to facilitate the passage of the balloon expandable valve. Here is the septostomy here, you can see. So blood pressure settled. I mean, it's about 80. It's not too bad. We didn't have to rush into some drastic measures on that. So balloon septostomy. What is interesting is to look at the color on the anterior leaflet. So there's now a big hole there with some acute MR. But it was quite easy to control that. So we pushed the balloon in, we blocked the hole, so there's no MR now. And then over the other wire, we just advanced Myval, 29 millimeter. It was actually very easy to go, having the support of both balloon and the wire. And now we spend a little bit of time to identify our landing zone, because with TAVI it's easy. You put a pigtail catheter, you go with the pigtail here. We had our marker with the calcium, but the zone is a little bit wide. So we relied a lot on TE, and you can see that we want to be 20-80, so 80 in the ventricle and 20 above the ventricle. So Elias helped a lot here to identify where the valve is, and also looking at the fluoro. And of course, once we were happy with the position, we removed the body balloon and the body wire, and we just inflated. We did also a ventriculography to have another idea. Sorry, I think I advanced it Oh, sorry about that. I just messed it up, I think. Just give me 1 second. And this is the inflation of the valve. You can see that here now. Deflation. And while we were assessing the immediate echo and hemodynamic result, basically what we wanted to see if there is a valve stayed in position, which it did, if there was any major PV leak, which there wasn't. So you can see on the echo on the top left. And of course, reconnect the LV and the aortic pressure. And initially there was a gradient, but the anesthesiologist gave some catecholamines. But as the time went by, there was no gradient at all. And you can see on the echo, there's actually, the valve is protruding inside the LVOT, but there's no leaflet. So actually the flow is going there without much of a hurdle. There's some turbulence from the frame, but the frame has open cells. And if you see second by second, the gradient between the LV and the aorta is getting lower. The patient was hemodynamically very, very stable with that. So we just removed the wire and we did all our hemodynamics. And this is the echo result. So you can see there was some trivial paravalvular leak on the lateral end. But the valve is working pretty well. There was no gradient in diastole. Here is how the valve is actually protruding inside the LVOT, but you can see the aortic leaflets are opening nicely. And there was no LVOT gradient. This is how it looks on the 3D, and this is how it looked the following day. You can see it's protruding, but this part of the valve has open cells. And this is the case. Thank you very much.
Okay. Thank you so much. You extended the Dr. Savi's introduction for the yellow and red zone. It was a red zone, Dr. Savi.
I think it was an excellent case, really. An excellent case, beautiful result. Do you use routinely 2 wires when you are doing valve in the mitral or any intervention in the mitral?
We use 1 wire, but we have used 2 wires for valve in valve, particularly when our trajectory has been difficult. So transeptal puncture for valve in valve cases or even valve in ring cases is very important. You have to go inferior posterior puncture in order to have an optimized trajectory. And if you cannot achieve that, then having a second wire or even a body balloon can help you achieve that trajectory. But here, it was very important to have 2 wires because first, you didn't want to put a balloon in and take the balloon out and then take your time to put the valve in because of this hole in the acute hemodynamic effect, which was unknown. This patient was not conditioned for mitral regurgitation, so we had initially physiologically mitral stenosis and then acute MR. Patient tolerated quite well, but when you put the balloon, the deflated 14mm balloon into the hole, pretty much you plug the hole, so there was no issue. So you had your time to push your valve in. It was our first case. We plan to do 2 more. These are, of course, patients that have no options. And it's compassionate, really.
So, may I ask a small question? So, Vlasi, would you wait for these patients to have a specialized valve like Intrepid or?
I think with this LVOT, from the TMVR devices that I know, the only device probably that could work is AltaValve because of this unique supraannular fiction. But right now, AltaValve cannot accommodate stenosis with small annuli and heavy calcium, only regurgitation. So really, I don't see that we have any other option.
If the patient had a less complete calcification, less round calcification, would you still do it?
Well, that's, as you understand, we went through this case after having lots of email exchanges with Tarek Helmi, Paul Soraja. Paul Soraja did a case, and this is why I took the initiative. And he sent me the case, and then I sent this case to him. He said, don't do it, there's not enough calcification. But speak to Tarek Helmi. So I spoke to Tarek Helmi. Tarek Helmi, do it, I think you can do it. So we discussed with the patient, we agreed to do it. But the problem is, if you don't have enough calcium, you don't have enough anchoring, your valve can embolize because the closing forces on the mitral are higher than the diastolic forces on the aortic. So you really have to have good anchoring. Potentially, however, implanting the valve into the anterior leaflet can give you extra anchoring because you've got an additional sealing skirt. And what was interesting, because this case came from our surgeon, the following day he had a surgical endoscopic replacement with MAC, and he said, I'm going to do the same concept endoscopically. So instead of removing the anterior leaflet, he cut it in the middle, he pushed it to the right, and he implanted the valve with stitches, of course, inside the leaflet, and he liked it a lot. So maybe there's a concept there. I mean, it's very early to say. I mean, it's just one case.
May I remind the people that were here last year that Nikitopoulos presented last year in this conference the Batman technique, so he has an excellent result. So maybe this has been... Yeah, exactly, yes. So that was good.
So I think it's only the very last questions. Once again with you, we are running behind the time. I think it's, please.
The last question, but I make a comment. Vlasis, thank you very much for this excellent case, but I want to alert and take into account about the aortomitral train.
Exactly.
This is very important, and sometimes it will be very dangerous if you haven't got a complete ring, and if you do tip to base to lampoon. This is why base to tip lampoon is recommended. With MAC, for this case, really, I think you make a lot of effort and think about the balloon size, etc. Maybe it will be a concept. But if we inflate the balloon in the anterior mitral leaflet, if we cannot predict the TEER which go to the aortomitral train, that will be catastrophic. Batman, for me, very safe in patients with complete ring. But for the MAC, I think it's the first case maybe, and we must think about it.
That's absolutely right. All the cases that I've seen were with a hard stop, either a prosthetic valve or a complete ring. This is probably one of the first cases that is done in MAC, but the concept is there. Of course, it's a big concern. The reason, in order to avoid this potential, we undersized the valve. So we went to a 29 instead of 30.5 because we didn't want to overexpand it. But you're absolutely right. We have to explore this field and see if there is any future in it.
Okay, we have concluded the session. Thank you, all of you, for the participation. And we're running behind 10 minutes more.